So CKD plus PD factors. So the question is, describe the pharmacokinetic implications of severe chronic kidney disease using examples of the drug using anesthetics to illustrate your answer. So the way you answer this is define CKD and then just go add me. And then PD. So they've actually only asked for pharmacokinetic factors. So severe CKD or CKD is reduced GFR for 3 months, and then severe CKD is GFR less than 15 or dialysis dependent. So PK, you got absorption. The thing that you need to remember whenever you hear CKD, you have to remember uremia. And so you have to remember uremia. Okay, so you can either remember that by, I just wrote it here, urea, and urea obviously is important in kidney function for the vasorector countercurrent multiplier. So you need to remember that urea. Anyway, so increased uremia, so you get nausea and vomiting, so you get decreased gastric motility, so you get absorption. Topical, you get fluid overload, and so you got increased edema, you got increased diffusion, so reduced absorption. Then you have cardiorenal, where you have decreased blood flow to the skin, so you have reduced topical. Now the thing that's important with cardiorenal is that cardiorenal could be from the cardio and then affects the renal, or could be from the renal and affects the cardio, while hepatorenal is affecting the hepatic, so the liver, and then affects the renal. So distribution, so body composition. Our mnemonic is COPS, so we can talk about cardiac output first, and the S1 is special population body composition. So fluid overload, increased VD for hydrophilic drugs. Dialysis normalizes the VD. Then you have protein binding, decrease albumin, decrease oncotic pressure, fluid overload, increase VD. Decrease albumin, decreases protein binding, increase unbound drug, but also increases clearance. Increase alpha-1 glycoprotein. Why does it do that? Because you have inflammation. It's an acute phase reaction, decreases unbound drug, so particularly in basic drugs. So it does the opposite of reduced albumin, right? Because you have increase. Then you have drug interaction to, that's the other question, so it's not right. And then cardiac output, as we said, COPS, so cardiac output decrease, cardiorenal symptom, higher peak plasma concentration but slower time to peak effect. Blood pH, remember our mnemonic COPS, right? Blood pH, metabolic acidosis, acidic drugs, more unionized, less unionized basic drugs. Then metabolism, hepatic metabolism, you can have hepatic renal syndrome, impaired hepatic metabolism. You also have urea, which inhibits the CYP450, reduces metabolism. Things that induce, squeeze, phenytoin, pregnancy, which is progesterone. Things that inhibit, estrogen, uremia, warfarin, amiodarone. Then we have elimination. Renal elimination is reduced, may need to dose reduce, drug changing, dose interval. Accumulation of active drug. Pancuronium, I was wondering, 80% is excreted unchanged, and so increases the duration. M3G, M6G, respiratory depression. Dialysis causes variable clearance of the drug. Small unbound tend to be cleared by reduced VD morphine. Large bound tend to be not to be affected. Example, increased VD. Example, so drugs that are small, they tend to be cleared. Example, reduced vomit by large. So basically, small bound drugs get cleared, but high bound drugs don't get affected. small unbound drugs. Small unbound drugs. So, like for example, hydrophilic drugs that are low VD don't get. It says morphine, but I don't believe it's morphine. Morphine's high VD. So low VD hydrophilic drugs get cleared, but high VD lipophilic drugs such as fentanyl don't get cleared because they're bound and they large. And then, even though the question said only PK, but we also should say drug sensitivity, reduce seizure threshold, increase of local anesthetic systemic toxicity, electrolyte imbalance, alter drug efficacy, example digoxin hyperkalemia, increased risk of nephrotoxin. So, no. Question didn't ask PD.